Hello, my name's Dr. Roger Henderson, and I'm a GP in southwest Scotland, and I also co-host the GP Notebook study groups. Welcome to this GP Notebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. Now, you can find us on all major podcast platforms, including Spotify, Apple Podcasts, and Google Podcasts, so do please follow us to receive notifications about new episodes, and if you like what you hear, do please consider leaving a review to help other listeners find us. You can also follow us on Twitter at GPnotebook for more information about new podcast episodes and study groups. Finally, you can visit GPnotebook.com for podcast episode show notes and to find out more about upcoming study group meetings which occur all year round. Now, in this episode, I'm going to be discussing tinnitus, which is the conscious awareness of sound without any identifiable corresponding external source. Now, tinnitus sounds vary from person to person, but most people commonly report the sounds as ringing or hissing or humming or roaring or even a sound like static. And it can result from any disturbance to the ear or the auditory pathway, although as I'm sure you know with your patient with tinnitus, a cause isn't always easy to find. And estimates are that up to 10% of the adult population may experience tinnitus at some point in their lives. So we are talking significant numbers here. Now, we can also look at primary and secondary tinnitus because this is often mentioned in management and treatment techniques. So primary tinnitus describes tinnitus that's caused by symmetrical sensorineural hearing loss. So typically age-related hearing loss here, presbycusis, and noise-induced hearing loss. And primary tinnitus is the most common diagnosis in our patients that present to us with tinnitus. Secondary tinnitus, on the other hand, describes tinnitus with an identifiable cause other than symmetric sensorineural hearing loss. And you can get things like cerumen impaction and infections that are causing this. And although it's less common than primary tinnitus, it is usually important to identify it because many of its causes are treatable. Now, there are well-known risk factors for tinnitus, and perhaps the commonest here is hearing loss, because it's been estimated that between 50 to 90% of people with tinnitus also have some degree of hearing loss. And not surprisingly, tinnitus prevalence also increases with age, and this relationship is likely associated with progressive age-related hearing loss. Noise exposure, either occupational or recreational, is also well known to be associated with the development of tinnitus, and it's also often accompanied by noise-induced hearing loss. But something that's often forgotten is that smokers are more likely to experience tinnitus than people who've never smoked. Now, when we're assessing our patients initially with their tinnitus, we should focus on ruling out potential secondary causes, because, as I mentioned, these may be easy to treat. But first of all, ask the patient to describe the tinnitus for them. What does it sound like? Is it heard in both ears, or just one, or even elsewhere inside the head? Is it intermittent or continuous? Is it pulsatile? Does anything make it better or worse? And if you find associated symptoms, that might increase your suspicion of an underlying cause. By which I mean, if the patient reports something like otalgia, say, or otorrhea or oral fullness, then you should be considering if there's middle ear pathology here. If there's vertigo, then you should be thinking about a possible inner ear disorder. And if you've got a patient with Meniere disease, remember these usually present with a distinctive combination of episodic vertigo and fluctuating unilateral oral symptoms, including tinnitus. Now, one of the things we sometimes forget to ask our patients with tinnitus is about their medication, because medication, either over the counter or prescribed, can significantly trigger tinnitus. So examples of these would be over-the-counter medicines such as non-steroidals or aspirin. But then we've got things like loop diuretics, macrolide antibiotics, aminoglycosides, and things like cisplatin in some cases. Now, if you discontinue things like loop diuretics, probably within 24 hours you would hope to see a deterioration in tinnitus. With aspirin and non-steroidals, that might take up to 3 days. The macrolides could take up to 3 weeks. And unfortunately, with things like the aminoglycosides and things like cisplatin, that is often irreversible. Now, another thing to remember here is that by definition, people with primary tinnitus have symmetric sensorineural hearing loss. Conductive hearing loss, on the other hand, or unilateral sensorineural hearing loss, indicates secondary tinnitus. So always inquire about hearing difficulties and occupational and recreational noise exposure. Now, if you've got hearing loss suspected from the history or a very brief hearing check that you've done, we should then move on to things like the tuning fork tests, classically the Weber and Rinner tuning fork tests, because these can be used to check for the presence of and to differentiate between conductive hearing loss and sensorineural hearing loss. But both tests operate on the principle of comparing air conduction to bone conduction, and this should always be used together. But do remember here that tuning fork tests are not diagnostic, and so we should only be using them to help direct further assessment of our patients with tinnitus. And also, they may not produce entirely accurate results in patients with severe sensorineural hearing loss. So let's look at the Weber test first, which you may use on a regular basis, but if you don't, remember that this detects patients with unilateral or asymmetric hearing loss. So you use a 512 Hz tuning fork and you hit it very lightly, usually on your knee. You support the back of the patient's head with one hand, and you use the other hand to hold the base of the tuning fork to the middle of the patient's forehead. You then ask the patient whether the sound is louder in one ear. Now, if the sound is heard equally in both ears, this indicates normal hearing or symmetric hearing loss, such as age-related hearing loss. If the sound lateralizes to one ear, this indicates unilateral or asymmetric hearing loss, and lateralization may indicate conductive hearing loss in that ear. So if you have an abnormal Weber test, in other words, one where the sound lateralizes to one ear, we should then go on to perform the Rinne test to determine whether there's conductive hearing loss in that ear or sensorineural hearing loss in the opposite ear. So the Rinne test then identifies patients with significant conductive hearing loss, and we test each ear separately. So again, we hit a 512 Hz tuning fork lightly, usually on the knee or a firm surface, and you hold the base of the tuning fork not to the forehead, but to the patient's mastoid process for a few seconds. While the tuning fork is still vibrating, hold it near the ear canal, and you ask the patient which position lets them hear the sound best. You then repeat that on the other ear. Now, patients with normal hearing or sensorineural hearing loss will hear the tuning fork best when it's held near the ear canal, and that's a normal result or a positive Rinne test. Patients with significant conductive hearing loss, though, will hear the tuning fork best when it's held to the mastoid process, and that's an abnormal result or a negative Rinne test. So just as a reminder of those interpretation of the Weber and Rinne tests, with normal hearing, the Weber test is midline and the Rinne test is positive. With sensorineural hearing loss, the Weber test is in the unaffected ear and the Rinner test is positive, and in conductive hearing loss, the Weber test is in the affected ear and the Rinner test is negative. Now, we shouldn't forget about referring patients with red flags to secondary care, and I think it is worth mentioning these if we're assessing a patient with tinnitus. So red flag symptoms would include things like tinnitus with a focal neurological deficit, tinnitus with vestibular symptoms, and that should have an urgent referral if those symptoms are severe, tinnitus with sudden hearing loss, by which I mean over 3 days or less, pulsatile tinnitus, and tinnitus with unilateral or asymmetric hearing loss. All those should be viewed as red flags. Now, general measures when we're looking at the management of tinnitus include digital-related cognitive behavior therapy, better known as DCBT. And this is a form of CBT that's delivered using digital technologies, such as via a computer or a tablet or a phone. And it's very similar to face-to-face CBT. Individual tinnitus-related CBT may also help, delivered by psychologists. And for many years, we used to talk about tinnitus retraining therapy in our patients. But NICE now consider that the evidence base for this form of therapy is limited and so is no longer recommended. If you've got a patient with tinnitus and hearing loss, then amplification devices may be helpful. And we used to also use masking devices, sometimes better known as sound therapy, in the past. But NICE again feel this treatment modality does need further research. But many people do use them, such as white noise apps, and these are accessible and safe when used intermittently. So if your patient is using sound therapy as a tinnitus management strategy and they feel it's helping, even though the evidence base is limited, there is no reason to suggest they should stop doing that. Sometimes patients with tinnitus ask for drug treatment to help with their symptoms, and they can be desperate at times and come to us asking for medication. However, unfortunately, NICE has not found any evidence to recommend any particular pharmacological therapy, although many have been tried in the past, such as anti-vertigo drugs and anticonvulsants. So unfortunately, with tinnitus, the drugs don't work. Surgical treatment is almost never used unless we've got something like an acoustic neuroma, which can be treated surgically, and we've identified that. So hopefully that's been a very quick reminder about the basics of tinnitus and may be helpful the next time you see a patient with this common condition. And I do hope you found it helpful. But have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you'd consider following the podcast and leaving us a review on your favourite podcast platform. Do feel free to get in touch via social media at GPnotebook or email us support@GPnotebook.com if you have any questions, comments, or even ideas for future podcasts you'd like to hear. You should also visit us at GPnotebook.com to register for our year-long round virtual GP Notebook study groups and to download free shortcuts to help improve the lives of our patients in primary care. But as always, thank you for listening, and until the next time, goodbye.